Hello and namaste to everyone. I am Dr. Suwash Baral from Nepal. I am a dermatologist and dermatopathologist working in the field of leprosy and other skin entities in Nepal. First of all, I'd like to thank EADV Tropical Dermatology Task Force and GLODERM for giving me this opportunity to share leprosy and leishmaniasis in Nepal. Regarding, there is no conflict of interest in this presentation. So coming to the background, Nepal is endemic for leprosy and visceral leishmaniasis. However, the presence of visceral leishmaniasis makes the country endemic for post-Kala-Azar dermal leishmaniasis as well. And cutaneous leishmaniasis cases have been increased in the past decade, but still under-recognized and under-reported. However, there is a good established government program and support system for leprosy and visceral leishmaniasis, but the support system for the diagnosis and management of post-Kala-Azar dermal leishmaniasis and cutaneous leishmaniasis is still weak. Coming to the situation of leprosy in Nepal, Nepal has achieved elimination of leprosy in 2010, that is less than 1 case per 10,000 population. However, after in this last 14 to 15 years, the number of leprosy cases are decreased very slightly. And we are still getting, if we look at the indicators, we are still getting the child cases, grade 2 disability cases, and the MB cases among a lot of MB cases in the new cases. So these are some of my patient from the last 1 year at the child cases. We are seeing the children of this severity. So with the child case with the numerous lesions, child cases with the reaction, child case with the higher spectrum with the nodules and plaques, and multi-case family with the in the same family we are getting 2 or 3 children. Similarly, in the multivascular cases, these are the cases from my clinic in the last 3 months, and we are still seeing the MB cases with the leonine faces and even with the palatal nodules and the nodules on the trunk with the severe multiple nodules. These cases have very high BI and are a potential risk for the transmission of leprosy. And we are still seeing the grade 2 disability cases with of this severity with the, some of the cases coming with the bilateral hand clawing and even with the both eye lag of thermus. The cases, those are not under the leprosy indicators and not under the leprosy surveillance radars are those cases who have already developed anesthesia in the hands and feet, and they are suffering with the recurrent trophic ulcers. And these cases can, in the long run, develop a lot of deformity and also may change into the malignancy. And some of the cases of the squamous cell carcinoma in the feet with trophic ulcers. Now coming to the leishmaniasis. Visceral leishmaniasis is around 200 to 300 new cases annually reported in Nepal in the past 10 years. And they are actively recorded and reported. However, there is no strong surveillance system for the post-Kala-Azar dermal leishmaniasis. And regarding cutaneous leishmaniasis, its autochthonous cases are identified in Nepal for past 10 years, and there is steady rise in the incidence observed in the last 10 years of the 10 years period. Now coming to the post-Kala-Azar dermal leishmaniasis, there are relatively fewer cases, but often misdiagnosed due to close clinical resemblance with the leprosy. Usually lesions are asymptomatic early and later can cause disfigurement. They act as critical reservoir of parasites, and they are the source for the outbreaks of visceral leishmaniasis. So let's come to these 2 cases. If we just look at them, it's very difficult to tell whether the case is leprosy or post-Kala-Azar dermal leishmaniasis just by seeing clinical pictures. So both of them have the nodular type of lesions and infiltration on the face. But the first case is lepromatous leprosy with a lot of bacilli, and the second case is post-Kala-Azar dermal leishmaniasis with a lot of LD bodies in the dermis. So these are some of the cases I have diagnosed in the last 2-3 years with the PKDL, the diffuse infiltration of the face and nodules on the nose, perioral shiny nodules. These all cases are referred to me with the suspicion of leprosy. So also you can see the PKDL cases with the macular type of lesions, plaque, or sometimes even if left untreated, they can have a plaque or nodule type of lesions. And they have LD bodies in their dermis, and they can be the source of visceral leishmaniasis outbreak. So we can see in the later stage of the PKDL, we can also see the ulcerated lesions, especially in the non-trophic area. Now, coming to the cutaneous leishmaniasis, it's a new burden before old ones are detected, since we already have leprosy and PKDL, but cutaneous leishmaniasis is the new burden for us, and it's an emerging endemic, often misdiagnosed as other cutaneous infectious diseases. There is no systematic reporting in the government. So, in my experience from my clinic in the last 5 years, I have diagnosed 22 cases of cutaneous leishmaniasis, and among them, 10 cases are misdiagnosed, and mostly they are misdiagnosed as cutaneous tuberculosis. And there is a huge gap, research gap in cutaneous leishmaniasis in Nepal. And these are some of the cases that I have diagnosed in my clinic. With the most of the cases are the lesions on the face, with some of them also having mucocutaneous type of leishmaniasis. And there are also extrafacial sites with large plaque. Also you can see a large plaque in the thigh, and also other area of the body. And we are also seeing the child cases of the cutaneous leishmaniasis, and which are very difficult to treat since we have a limited treatment options for cutaneous leishmaniasis. Now, coming to the conclusion, Nepal has achieved elimination of leprosy, but we are still struggling to decrease the disease burden of leprosy in the last 15 years. Regarding post-sclerodermal leishmaniasis, it's there in Nepal, but it's underreported, and they can be a very good reservoir for the visceral leishmaniasis outbreak. So we need to do surveillance for development of PKDL in cases of visceral leishmaniasis. Cutaneous leishmaniasis is a recent emergence in Nepal, so we need a lot of advocacy in medical fraternity, also in the government programs, and we need a lot of research in the field of cutaneous leishmaniasis to identify species and the treatment modalities. I'd like to thank Anandaman Hospital and the other doctors, those who have supported me. And lastly, I'd like to thank all of you for listening to this presentation. Thank you.